first of all, thank you, Kent and Marie, and everybody for a really fascinating meeting. Of all the meetings I go to, this truly is, I think, one of the most special and one I learned the most, and I'm pretty much honored to be here. I was here in one of the first of these, and I did discuss some elements of what I'm going to discuss today, a way of changing pulsations in the brain and trying to figure out what effect that has. Today I'll be discussing some things that we're recently publishing and things that are in preparation as well. Funding has come from various sources during the year, during the time, NIH, research funds, and investment funds. And I'd like to start off also by thanking a large group in Baltimore from various, mostly engineering disciplines that have been collaborating in discussions to move this to the next level. Also, I have collaborators that I think many of you all know here, Francis Loth, Sarah Kvarlander from OMEA, who have helped me in the past, and this is a publication from 2017. This is what I discussed earlier on. And also now collaborators from a paper just submitted and in preparation. And that'll be the focus of what I talk about today, mainly looking at effects on blood flow. So this is a super simplistic diagram, and I don't have to tell anybody in this room that obviously the brain is not really a quiet space at all. The brain is dynamic with every cardiac cycle, and it is it's a Monroe-Cully doctrine, but in every heartbeat. And we know that when the blood swells in with systole and actually swells up into the entire vascular system, fluid has to move out of its way. And we all know that room is made through movement outside of the skull into the spinal canal, and also room is made, of course, by compression of veins. We learned yesterday, seeing a similar diagram form, that obviously the CSF also often moves the quickest, and it's because of its fluid nature. The venous perhaps a little bit slower because of viscosity. And I think that's one of the main purposes of CSF in the brain, is not just to float the brain or to cushion it, but it is fluid, and it can move very easily and allow movements of the brain due to any changes, including cardiac cycle changes. So if this motion of fluid getting out of the way and with every systolic blood wave coming in, moving down the spinal canal, helps blood flow in any way, and this, a few years ago, there was a concept, well, still is a concept, of the Wind-Kessel phenomena, where the elasticity of the artery stores the energy and it transmits blood more during diastole, giving a more even flow through the capillaries throughout your body. This could not happen in a rigid skull unless there was something like a fluid system which could move and get out of the way and allow the pulsations to occur of those vessels. So it was Duroka back in the 60s who thought of putting a balloon into the cranial space. He was a pediatric neurosurgeon. At that time, he put a cardiac-gated balloon into the ventricle itself just to see if it would increase the size of the ventricle, if pulsatility itself would do that. We thought of that balloon, but in a different way, thinking, what if we could start a balloon? Let's see if I can start the balloon. Here we go. And have it synchronized with the cardiac cycle, and in a way, allow more CSF volume space at critical times in the cardiac cycle. In this case, and it can vary, and it will vary in what I go over, it shrinks down when the blood is coming in and swelling all the vessels in the brain. So this is the basic kind of manipulation that we thought would be interesting, both as a tool to understand how impulse change might affect the physiology of the brain, but also have potentially positive effects on positive and clinical effects on brain physiology. Now, to a neuroscientist, I think that this is totally alien, aphysiological, and to an engineer, it's probably too simple with a piston engine and too complicated in many other ways. And but to a neurosurgeon, this is kind of insane, I think, because the idea of putting something moving into a skull sounds dangerous. And indeed, a lot of our efforts have gone to have it embedded in the skull in various ways, put it in places where there's CSF space, and to have it in various shapes that it will not impact on the brain itself. And I should mention, I'll be talking in more detail about it later, that they're designed to only really change microamounts. The amount of excursion of these balloons is usually less than a millimeter. So it's a very small amount, but it's enough with the volume and the distribution to create differences in pressure. So Cardiac gated oscillating intracranial or spinal device which can alter intracranial pressure pulsation. And this can be an approach to study the effects of ICP change that we see from cardiac cycle. And also, it is possible, and this is farther out there, of course, although there are some applications that are closer. Something which may enhance blood flow may very well influence drug delivery or brain clearance. And this is the clinical reasons, of course, that we give when we go out to seek our funding as well. So as we said, of course, there's no way you change one system adjacent to a CSF space and without causing CSF flow changes throughout, causing changes in what we've come to hear about, the CSF interstitial fluid and its flow as well. So all this is connected, and we know that we'll be changing everything. And when I talk about flow of fluids, I really won't be looking at flow of fluids. As we all have been cautioned here, of course, we're looking here mostly at movements of tracers when I get to that at the end of the talk. So this sort of idea, of course, in terms of ICP, can be considered global. Well, we measure the ICP when we have this device on one side, we measure it on both sides, and both sides have a modulation of the ICP pressure. However, it's really also a local device in terms of the way it is changing and rerouting CSF flow, and obviously will have different effects, whether it's in different places. And you can envision it as an epidural, as we talked about, and the studies here are mostly epidural. We've tried a little bit lumbar, and we have designed a system on a ventricular catheter design to go inside at least larger ventricles. So the different embodiments may be used in different ways, and different shaped balloons. For example, a long, flat balloon can go in through a burr hole, have a longer distribution, and have very little excursion in the epidural space and have an impact. And other ones might be longer for the spinal canal and so forth. So let's look at the experimental setup and how we study how a system like this might affect blood flow. We have the balloon implanted through a burr hole, and in this case, it was put in, on basically the frontal parietal cortex and in the Sylvian fissure. And animals are anesthetized, isoflurane. The balloons themselves, as I mentioned, 2 millimeters in thickness, and this one in particular was 5 millimeters in width and 5 centimeters in length. It was a long strip. This allowed a good distribution of space for a very low profile device. We've also been embedding these into the skull a bit so that they don't protrude in any way as well, or very little. To this, we add ICP probes and blood flow probes using 2 types of blood flow measurement, laser Doppler and thermal dilution. All these focal measurements of blood flow, but we have multiple on both sides. The setup itself, we monitor the heart with an EKG, digitize it, have a digital delay which starts a pump, triggers a pump at various digital delays after the R wave is recognized. So it's synchronized the cardiac cycle. We also can, through a programming system, change the shape of the balloon. Does it go up? Does it have a plateau? Does it come down? Is it a sharp up sinus wave? And so forth. So we can adjust the shape of it and the delays and the timing and, of course, the amplitude of the waves going in. From that, we then measure intracranial pressures, cerebral blood flows bilaterally, arterial blood pressure, and, of course, heart rate as well. So here's an example. This is actually from one of the early animals that we can affect the ICP pulse wave. Here you see on the panel on your left, the system is off. The balloon is not moving. This is motion of the balloon at the bottom. At the top, we see the ICP. And typical, it has the respiratory waves, it has the cardiac superimposed upon them. When we turn the system on, we see the balloon activity. The EKG triggers a downward movement, in this case, of the balloon. And then upward, in this case, there's no plateau in the design of this one. And when it does so, you can see how there's a reduction in the cardiac rhythm. And you might also note that there's very little change in the general ICP average, mean ICP. So we have a system which can really kind of knock out a component of the pressure changes in the cranium by this individual cycle approach, but leaving the general mean pretty much intact. And I'll show you, there are significant differences, but they're quite small. This can go on for minutes, hours, or, well, the longest we've done it is about 12 to 14 hours. The effect stays intact pretty much until you turn the system off, and then the cycles come back. So we have a pretty precise way of changing the pulsatility in the cranium. And we can take advantage of that by studying what happens when we turn it on and turn it off. Well, as you saw, there is a very little effect on the mean. ICP, it's about 14 to 9% across animals, and less effect also on systemic variables, such as the arterial blood pressure and heart rate. Very low percentages. However, there is sometimes as high, and it's quite variable, but sometimes as high as 4 or 5 times increase in the systolic pulse pressure changes and the general pulse amplitude. So we can change that. You may not be able to see this very well, but we put the balloon here. We've done really rudimentary histological studies, gross and routine staining, and for 4 hours, that's the time of most of our studies, and have not found any contusions, at least with this preparation and the way we've planned it. There's a lot more to do, of course, in pathology. To get onto this specific study, what is the best protocol to use to achieve changes, for example, in blood flow? And I can't really say that this says the best protocol, but it chooses between 3 major kinds. One is to inflate the balloon during systole, and that would be this blue curve, inflation of the balloon during systole. And that takes the normal, which is that black ICP pulse, and gives you that blue one that's higher. I'm not sure if you see the colors. But that's called augmentation, of course. If you can also, during systole, decrease the balloon, and that gives you a decrease in the pulsation. And you can even decrease the balloon so much during systole that you reverse the direction, and it actually becomes smaller. The ICP goes down during systole. There's often a rebound that goes higher afterwards, and the result of this is that the actual amplitude of the oscillation of pressure is actually increased from normal, but it's in a totally different direction during systole. So those are the kinds of manipulations. We call them augmentation, reduction, and inversion. And what do we think would happen with each of these protocols? Would it make a difference? You have something that's pulsating over the dura, and I should say that the energy of the pulsation with the augmentation protocol and the pulse inversion protocol is essentially the same. The balloon is going the same amount of time, synchronized with the cardiac cycle. So the amount of manipulation, if you will, of the dura is the same, but it's a different phase. So what difference does it make? So to study this, we took the canine model, and here you have a listing of dogs. This actually reads this way. You may see it better as linear up here, but it goes across. Each animal gets all 3 types of protocols of balloon inflations. The system goes off, then on, then off in the sense of washout period, then on again. All animals get all 3, and they all get them in a random order. So we wanted to have a pretty well controlled, because as you can imagine, there's a lot of variables between dogs, and there's variables in time, even minute to minute or hour to hour in these animal preparations. So to eliminate as much as we can and control for this, we designed this study to really see what happens when we increase the pulse wave, when we decrease it, or when we reverse it, when the system goes on and then off again. So this is the data we collected. We looked at the ICP pulses off, then on, comparing, and you'll see delta ICP pulse, and that's what that means. It's comparing the off to the on. What kind of change did the system create? As we saw, the ICP actually is changed a bit. It's actually increased a little bit with augmentation and decreased in the other 2 systems. That increase is a relatively small percentage, but it is a decrease in the ICP mean. The ICP amplitude is increased to a great extent, and as I mentioned, both protocols, the augmentation, which is now here, and the inversion is here and the augmentation is here, both increase ICP pulsations and decreased, as you would know by the name, in the reduction protocol. Finally, trying to focus in on what happens when the blood wave is entering the skull, the IPC systolic amplitude. We know that with augmentation, it's changed and it goes up, but it is pulled downward, most in the inversion protocol and also in the reduction protocol. Now let's look at blood flow. What happens with blood flow, this time measured by thermal dilution. By thermal dilution, this is the individual data, and then the averages of the individual data. This has a graph, and I like this because it gives a perspective of the total cerebral blood flow and then how much of it's changed. You can see the changes here occur. There's tendencies, but not statistically significant with augmentation. But then there's significant increases in the inversion. Again, these are modest changes. It's not a high percentage of the total blood flow, but in many of these animals individually and also on average, it is reaching levels that can be physiologically significant and increases with the inversion protocol. It did not increase significantly with the reduction protocol using this measurement technique. And here you see graphed that the inversion protocol, and mostly more ipsilateral than contralateral, but significant in both cases, causes increase in the cerebral blood flow, mean. This is with laser Doppler measures, probes again on both sides, and I'll simply say that the pattern is the same. It turned out that there was a significant difference seen with the reduction as well, but you can see here essentially the same pattern. There were no decreases in blood flow. Even the augmented had some increase, while the inversion protocol created the greatest increases in blood flow. Let's look at the systemic effects. The heart rate did change, and of course that's important. The change in heart rate or pressure can of course affect the blood flow, cranial blood flow. However, you'll notice that it's quite small. The only one that was significant was the inversion protocol, and it was about a little more than 1 heartbeat per minute greater. So a very tiny increase, but there was an increase. Similarly with arterial blood pressure, about 2 millimeters of mercury increase with the inversion protocol and less with the others as well. So there are very small increases. But when you look at the systemic effects and include the cranial pulse effects and look at CPP, the cerebral perfusion pressure here is really measured by the slope going down, the negative pressure created by the cadence system, and taking into account, of course, the arterial blood pressure. And you can see that these two protocols that reduce the ICP pulsation also increased blood flow. They increased the cerebral perfusion pressure and expectedly increased the blood flow. But you remember that even though there's a decrease in cerebral perfusion here, there was no decrease seen in the blood flow. So that's a bit unexplained. But the others two do certainly follow some pattern with cerebral perfusion pressure. To try and get an idea of what may be related to the changes that we're seeing, we did correlation studies, of course. And we found that when it came down to heart rate and blood pressure, the change that we saw with the system on was not correlated well with the cerebral blood flow changes that we saw. And we used only the inversion protocol because it had the most changes. It did, however, correlate very well with pulsation amplitude, general pulsation amplitude, and also the systolic effect. Let's get back there. And also the systolic pressure change itself. And it did not correlate well with the mean ICP changes. So this indicates that there may be a close association with the manipulation that we're making, the change in the pulse amplitude, as opposed to these average changes or systemic changes. So in summary, small but significant changes in ICP, larger percent changes in ICP pulse amplitude, and similar with the two types of blood flow measurements. Also, as I just mentioned, the dynamic correlation as opposed to with the systemic and the mean measurements. And the pattern was that decreasing, or especially inverting the IC pulse response to the cardiac cycle can increase cerebral blood flow. Well, back in the beginning of the talk, I talked about Wind-Kessel effect, and we thought that, well, maybe we're allowing more blood to be stored in the vascular system initially. And if there is a Wind-Kessel effect, then we would expect some smoothing of the blood flow itself into the brain parenchyma. Now, with the thermal dilution measurements, we can't measure any waveform. It's a mean measurement. However, with the laser Doppler, you actually do get a waveform. It's all relative. It's not quantitative. But at least we can see a waveform and see if it does change when we go from off to on and back off again in the system. So we thought to look at that. This was actually Sarah's work when she came as well, one of her projects. Let's see if we can get there. So we asked the question, is the increased mean cerebral blood flow associated with the decreased pulse amplitude of blood flow waveform in the brain? So here we're looking at pulsation of blood flow and not of intracranial pressure. And we thought that, well, if it was related to this quote, Wind-Kessel effect, there may be a smoothing of the flow through the interstitium, through the capillary system. So we may see less pulsatility there. What do we find? Well, here you see, in a case of augmentation, you see the ICP pulsation, cardiac cycle synchronization. Let's add the balloon. The balloon, as you saw, is going up during systole, and you have an increase in the ICP pulsation in the head. This is what we expect. This is what we learned from before. What does that do to the curve, the waveform of blood flow in the tissue as measured, or as indicated, I should say, by laser Doppler? Well, here's the flow that we see on the laser Doppler curve. If we add the balloon, we see that there's actually a decrease. Not great, but there is generally a decrease in the amplitude and not an increase with augmentation. With reduction, just the opposite. We see a increase. So you've reduced the ICP pulse, but you've increased the pulsation of fluid going through the brain parenchyma. And although this may not be what we expected based on the Windkessel effect, it certainly can be explained by the more basic, I guess, Monroe-Kelly doctrine. We're changing volume, we're reducing volume in the CSF space, and the blood flows in more quickly. So it's a relatively simple explanation in that sense. And then aversion is more complicated, but shows the same pattern. So when we look at the changes, they were significant. Oh, that's kind of darkened, but basically the systolic ICP showed the greatest relationship. When we change the systolic ICP in these various protocols, as it goes down, the blood flow pulsation amplitude, and that's not the mean blood flow, well, that does too, but the pulsation amplitude actually goes up in the tissue as indicated by laser Doppler. And there are some problems with laser Doppler, some concerns we had about controlling for things like motion. Here again, just illustrating a generally negative correlation. So what we found is that we can increase blood flow. It's highly variable. There's a lot of different changes in the waveform, in the amount of delay, and in the general protocol that can be looked at to figure out what are the best ways to change blood flow, if that's the goal, and also to understand how the CSF volume changes are relating back to pressure and flow changes. So just to keep score with what we did in blood flow, there was no decrease in blood flow with augmentation. There was not much increase, but there was indication of increase with reduction and much more with pulse inversion. And we did see changes in blood flow through the tissue, but it was a blood flow increase as opposed to a decrease. So this is what we are just submitting now. But the work that we're starting now is really going in a bit of the different directions that ICP modulation can perhaps involve. It started off, as I mentioned, with DeRocca back in the 60s. He looked at cerebral morphology and ventricular size. We've just been talking about effects on cerebral blood flow, and perhaps this might have relevance to things like vascular dementia, stroke, and acute and chronic states of blood flow. But I think very importantly, and also a major topic, of course, of these last days, has been the distribution of solutes and fluid in the brain parenchyma. And this applies especially in the clinical world to the possibility of altering dispersion of drugs into the CNS. And of course, perhaps with neurodegenerative disease, also affecting clearance. So these are obvious possible roles of the cadence system in the clinical spheres. We all have our favorite beautiful pictures of the flows. I'm not getting into any of this, shows a nice flow from artery to vein and so forth. The point of this is that we all agree that we don't know about the details of this as much as this picture might imply. But what I do sense is that we all kind of agree that pulsation plays a role in either facilitating dispersion or in convection. And changing the pulsatility may change the mix of and distribution of solutes. So based on this, I'll just go through this. This is especially true in drug development. Based on this, we've just started, and to be honest, I'd hope to get farther in this study to report to you. I think my report on this aspect will have to come at some later time, if possible. And we're starting a dog model, continuing our dog model, use of dogs, to bring the studies that Pierre Edie discussed with patients, the injection of gadolinium, the distribution, and of course have been done at the level of the rodent, but to bring them where they've not been done much, I think, at all in the dog, and get the parameters that we need to be able to look at the kinetics of dye distribution around the CSF spaces and then ultimately into the brain tissue. And that's what we're working on right now to make sure that we know how to get the parameters right, and we are practically there, but also then how to properly quantitate it. The reason we're doing it, of course, is because we would then want to make manipulations to see how that distribution changes. So we've looked at the different time points. And we've seen that the distribution is very similar to what's been described both on the one hand in the mouse and in the other hand in humans. So we think our model is going to be useful. And the reason the model is going to be useful is also because we can make manipulations in this large animal that we can't really do in the smaller animal. We can put shunts in. We can also use our model of obstructive hydrocephalus. This is cyanocrylic glue, which is placed into the fourth ventricle through a posterior approach and blocks up the aqueduct. We can create obstructive hydrocephalus chronically in these animals and also look at the flow. We can also shunt them, and we already just last week we shunted an animal and put it in a shunt with a variable system that we turned it off and we could turn it on, we could drain a lot, drain a little bit, and see the effect of treatment of hydrocephalus on distribution of tracers. We're using gadabutrol at this time, as is common, but we're also going to be using fluorescent dyes in doing histology. So in conclusion, we can modulate using the cardiac-gated implant. Blood flow increases are modest, but may be optimized. I will say that we're nowhere near optimization of this process even for blood flow. And the distribution changes in solutes, which may be of relevance to drug studies, are just being started. We've learned that the Monroe-Kelly doctrine governs, of course, a lot of our hydrodynamics and never bet against it, even if it's something like Windkessel. And also that this large animal model, I hope, can bridge the gap between mice and men, in that it allows us these manipulations we could do in the clinical setting, but also allows us the more detailed histology. We're going to be using different fluorescent molecules, different sizes, and along with the more anatomical detail of histology, along with correlation to the MRI studies in vivo. And I think that's it.
Thank you very much for that wonderful talk. Open to questions?
Yeah.
That's very elegant stuff, Mark. Just a word of caution, I'm sure you know the laser Doppler flow flowmetry is really very superficial. It's like a millimetre and very dependent on local blood vessels.
Mm-hmm.
So I wonder if there's an additional way that you could get information about deeper blood flow, maybe TCD or... I mean, you've got MR.
Yeah, that's possible. These are depth probes. These are probes that go in, so they're not surface laser Doppler. But you're absolutely right. It's a very small area. And it's quite honestly, we had it and had used it and had those curves. But you're right, it was just really a first look at a curve, just to see if would it get bigger than, by theory, or would it get smaller? And at least we have that information. But you're right, learning exactly what's happening in the brain in terms of the pulsation of flow is something that we would need to detail.
Any other questions? Kent?
Yeah, so this is perhaps more of a comment, but you have this concept of autoregulation in the brain, so that even when you exercise, if I triple my heart rate or the cardiac output, roughly the same amount is supposed to go through of blood is supposed to go through my brain. At least that's a saying, right? Mm-hmm. But then here you modulate the system very subtly, but still you see quite a remarkable result. Do we need to adjust this autoregulation?
No, I think that regulation is very much there. It's just that we've fundamentally changed. I mean, the skull is a rigid, container, and we're making one that's flexible and in a way that flexes with the cardiac cycle. So that's quite a change. And I think when we lower the pressure acutely around the area of the brain and the vessels, it allows more blood flow to come in just at the right time when it is coming in. And so it's a manipulation which is, I think, enough to overcome any immediate autoregulatory issues, which are, in terms of CO2 and so other respond also to other aspects.
Can you hear me?
Yeah, I can.
For patients who've had dura patches put in and no longer have a hard framework for their skull, how do you see that affecting ICP measurements?
Yeah. So, as I said, a lot of this depends on the rigid skull, and it is known that once we take that off, those vessels pulsate very differently than when they're contained within the skull. There has been some work that looked at the change in pulsatility. Also, there was reported there's decreased CSF flow going into the parenchyma when the skull was released. And so you might say that instead of being focused back downward, those pulsations, and perhaps enhancing fluid going back into the parenchyma, it was reduced. So I would say that taking off skull certainly changes the compliance. I mean, that's what we've done historically for many years, is taking off parts of the skull on purpose so that the brain has more compliance and the vessels have more room to expand, and the brain does. And that also changes the movement of fluid around the brain, and it also changes the movement of fluid into the brain. I think that's what we have to also consider here. It's not just making room, but it's changing the fundamental flows of fluid in the brain.
Do you think if you do the same approach, but inside the spinal canal, you will have the same results?
So we did 2 experiments. It was difficult because, as Mark said, there's no good CSF space in the spinal canal, and that was one of the issues. But we were able to create balloons and do that. Obviously, the spinal canal is a higher compliance region, and a lot of the motion can be absorbed in the spinal canal and does not get up top. So the answer is, it has the same effect, but much weaker, because less of the modulation ever reaches the cranium. We were interested in that because if we can ever insert these balloons spinally, then it might be a convenient way to do it. Maybe we can run it closer up into the skull. But if you're putting it into the high compliance chamber, it probably will have less effect than if you have it in the rigid cranium. Yeah.
Right.
Okay.
I think that's it. Thank you very much.